Welcome everyone to this podcast. Welcome Penny, Paul, and Dyke. Can you guys introduce yourselves? We're going to talk about physician burnout today. Very important topic. And I'd love for you to share some of your perspectives over the next few minutes. Thank you. Penny, you can go first.
I'm Penny Sempel, and I'm the co-founder of StressPal. And my background, just in a brief nutshell, is as an educator in integrative health education. And as an attorney, I focused on conflict resolution and mediation, and found myself with a wonderful group of professionals and clinicians to put together the StressPal program. StressPal takes a disruptive approach to self-care and uses digital tools to make it easy for organizations to be proactive for individual and team well-being and to strengthen a resilient culture where people want to stay. So that's, in a nutshell, what I'll say today.
Great. Thanks. Paul?
Hi. Thanks, Nick. Yeah, it's great to be here. I currently am coaching health system leaders around the country for the last 10 years on how they can help prevent burnout by fixing the workplace, complementing what Penny does to increase resilience. I'm focused on improving practice efficiency and in particular, improving leadership practices that address the drivers of burnout. Practiced family medicine for 25 years with progressive management roles at health systems around the country, was CEO of a 300 physician group for 5 years, during which time we implemented changes with the theme of returning joy to patient care and became recognized as the top performing medical group among 170 across the state of California 2 years in a row, while improving our physician satisfaction from P45 up to P87. And in the past 10 years that I've been doing the consulting, I've also written a book, Preventing Physician Burnout, Curing the Chaos and Returning Joy to Patient Care.
Dyke Drummond, I'm a family doc since 2010. My practice, if you will call it, has been exclusively focused on coaching, training, and consulting to help recognize and prevent physician burnout. I am an ICF certified coach. I was one of the very first doctors certified by the ICF in 2000. I've got a book, Stop Physician Burnout, What to Do When Working Harder Isn't Working. And these days, my 5-coach team focuses on individual burnout recovery coaching, and I focus on leadership development and system design like Paul. I typically don't get into the C-suite, though. I coach the leaders to be more influential in the C-suite to bring the practice of medicine back into balance with the profit motive of the organization.
So I'd like to start with a little perspective, since we all have gray hair here, those of us who have hair, just on how, burnout did not seem to be an issue 40 years ago. It might have existed, but it certainly was not a topic as much. And last year, I guess the AMA's survey, burnout is trending down, but still we're talking 45% of a surveyed physicians. But I'm just opening that up to anyone to comment or talk about either the trends or historically what has happened, what is happening.
You're right, Nick. 40 years ago, burnout was not so much a topic. There was burnout, but it's increased undoubtedly because the complexity of the work that we do increases. Certainly the pandemic threw a huge wrench into everything, dramatically increasing the stress. But even as we're recovering, there is improvement. But when we look at the cognitive workload that physicians are expected to do and the challenges involved in that, there's demonstrated physiologic and anatomic changes that happen as a result of that, as well as a lot of opportunities created now with technology, in particular, to reduce some of that burden if systems are willing to invest in making those changes. I'll stop there and let others jump in.
I would say that we first started measuring burnout in physician populations in the 1970s, Christina Maslach and the rest. And the background rate of burnout back then, and I'll just note that it was before the EHR, it was paper chart days, it was 30%. It's always been 30%. The challenge is we never surveyed for it before then, and nobody understood the links between that and the negative effects on physician performance. Let me just ask, what's an acceptable rate of physician burnout? I get the same answer everywhere I go. And usually I'm in front of an audience of at least 200 doctors. You know what they say? Every time, starts with a Z, by the way, 0. That's obviously aspirational, right? But what I'm fascinated by is that somehow the lay public doesn't know this. Somehow the lay public doesn't know that half of doctors are burned out, and they don't know how it affects the care that they get. But if they did, your mom might say, hey, Dyke, I'm going to have a doctor appointment on Wednesday. I guess it's just a coin toss whether I'm going to get good care or not. And she's not technically 100% wrong when she says that.
I think something that I would jump in on here is our increasing awareness of the impact of the larger team and interprofessional teams. It impacts clinicians and the high levels of burnout that also exists in clinician and non-clinician teams on which physicians are dependent to be performing their work well, whatever role that may be. And I think we're getting more of a sense of the impact of high stress and persistent stress in the larger workforce and how it impacts culture, and that as a contributor to burnout that perhaps did not get as much attention in the past.
Yeah, you're right, Penny. In fact, nursing burnout in those same surveys is increasing as opposed to physician burnout decreasing, and it's up around 70%. So it is significant. And actually, even 10 years ago when I first started doing the consulting work, administrators were not burned out more than the general public. Now their burnout rates are about the same as physicians and nurses. So everybody's feeling this. The other thing I'm finding when I try to talk with senior leaders about this is they're burned out on talking about burnout. They look around, they see everybody's got the same rates. They think they need to invest their time in other things because they've tried everything they can and have accepted the current state as an acceptable status quo. When I agree with you, Doc, the number should be 0 as an aspiration and certainly significantly lower than it is.
Let me just say one more thing. I talked to Christina Maslach back before COVID, and I asked her about this trend inside healthcare to switch from the word burnout to the word joy for some reason. Somebody plucked joy out of nowhere. And I noticed that she didn't use the word joy in this conference, and Tate Shannonfeld and Christina Maslach lectured back to back. So it was an interesting Texas conference. And I went up to her, by the way, she's a great hugger. And she still does research surveys with her study subjects. I said, Dr. Maslach, I notice you don't use the word joy. And I said, why? And she said, that's not the word my study subjects use. The people on the ground use the word burnout. People who are tired of talking about burnout use the word joy. But I'll maintain until I'm dead that if you start talking about joy rather than burnout, you have just separated yourself from any level of effectiveness with your people, because no doctor has ever woken up in the morning, a Monday morning, not enthusiastic about going to work and said, man, I hope I get some more joy today in my practice. They've never, ever said that. That's just not a word that they use. So it's burnout about burnout that causes people to say joy, but it doesn't help their effectiveness. And I've talked to people in senior leadership positions in a certain West Coast major burnout-proof organization that shall not be named, who do not allow the use of the word burnout inside the walls of their facilities. Just simply have outlawed it. We talk about joy. That's it. Dyke, see you later. Like that. It's weird.
I would push back on that just a little bit.
I'm sure you will.
Because the transformation we made with the 300 physician group that I was CEO of, we labeled it returning joy to the practice of medicine. And people were very skeptical at first. It took 5 years. And what it really took was active engagement by the senior leader. Now, I was CEO, and my full effort and focus on that and willingness to create a great team that was working on this as well and addressing the entire aspects really made a difference. I think when we look at burnout, I've worked pretty extensively with Christina. In fact, she wrote the foreword to our book. There's 2 key factors that really stand out. One is a driver, which she describes as job person mismatches, not just drivers, but it's the mismatch of the person in the job. The first is work overload, which she and her partners have demonstrated drives the exhaustion dimension of burnout. But the other 5 drivers, which are a lack of control, insufficient reward, breakdown of community, absence of fairness, and values conflicts, they demonstrated that those drive cynicism, which is a very different component. And I think ultimately a deeper driver than the work overload, because those 5 drivers that drive cynicism have everything to do with leadership. So we're starting to see some new things happening now where if you can impact leadership, the work overload reduction, practice efficiency improvements start to come into play because, as Penny said, the teams start working together better. All of that starts happening. We could go back and forth on whether you say joy or burnout. We're measuring burnout. We're not measuring joy. But I think we're aspiring to joy, not just the absence of burnout.
Here's the interesting one, too. If we're talking about leadership, first of all, people don't quit their job, they quit their boss. And Shannon Felt did a study years ago that showed that 40% of attendings at Mayo, 40% of their job satisfaction was related to how much they like their boss. Just straight out, 40%. So yeah, people quit their job all the time, bad leaders, but that's not limited to healthcare.
Yeah. The challenge with leadership is most people, we probably all experience this. We got into our first leadership position, not because we were great leaders, but because we were great at the job we were doing. And somebody above us thought, this person can do this job. If we make them the leader of that unit, then they'll teach everybody else how to do it the way they do. But they never had training in leadership. Maybe had skills in it if we were lucky, it's a crapshoot. But very few organizations actually invest in training their managers in leadership. And then their managers are reporting up to people who never got trained in leadership. And so we're creating this culture that's self-perpetuating as a result. And that's an area that is just starting to get attention, the attention that it needs. And all of us 3 here on this call are focused on that pretty intensely. But there's still a lot of work to do to get that focus within leadership and organizations.
And there's a whole nother part of this that I'm sure you all see, that we, as humans, we're working in this high-pressured, very unpredictable, challenging environment. And yet there really isn't structured training from the psychology and psychophysiology side on best practices for self-care of our cognitive functioning, our coping, basically our stress resilience and communication, conflict resolution, these kinds of things. There's very little training, yet we're in this really challenging profession. And I think we're starting to see some aha moments around is there bridges that we can make between advances in other fields to bring into training here as in organizational psychology toward leadership? Are there efficient methodologies, interventional approaches that can be readily taught to people across and up, the middle and up approach while you're doing the leadership approach, very important. Can you also support? And the answer is yes, there's excellent advances. I think one of the interesting things that I found myself looking at, and it was instructive to look at intent to leave. What are the things that come up? And there was a very interesting Press-Ganey report, and it's a large survey that was done that looked at what were reasons around intent to leave. And if you look at those, that a lot of those are around from my framework, from a more psychology approach, is how people react under persistent stressors, these external environmental stressors over time, these interprofessional factors. And what are some of those things right up there at the top of the list of why people say they leave? And on the converse, stay. Not feeling valued, a lack of culture of trust, a lack of respect, psychological safety, collegiality, loss of autonomy. These have a lot to do around culture and the way people are experiencing the stressors, their own stress-triggered responses, and those of the people around them. So I think, coupling what you were saying, Paul, about starting to see more a window of opening, how can we help leaders around skills in leadership? We also can very affordably and with digital tools start providing support right now for people in terms of how innovative ways to be interacting with the stress that they're experiencing and living the life they value. That's a term I like, living the life you value. It's close to joy, right? It's living the life you value may not always be joy, but it's coming from that positive place. And I'm increasingly finding that's resonating. I spoke to a large group of nurses this last week, and that concept, people can nod their head. Yeah, I want to live the life that I value. And is there training that I can get in this environment that I'm working in while you fix what's broke? that will help me do that.
That's great. That's great.
Actually, Betty, building on that, you're right. People have moved to places that are insisting on joy as the word these days. But even GHIN&F tried to move away from joy towards the term professional fulfillment. When you think about it, our jobs have so much opportunity for professional fulfillment. Where else? What are the professional people come to you and share their deepest, darkest secrets they'll tell no one else in their lives because they trust us. They trust us so much to even let us stick needles in them and cut them open to make them better. And we get to mentor young people preparing to become our colleagues. We get to redesign workflows in healthcare in order to make it better. There's just so many opportunities for professional fulfillment. And yet, one of the big challenges is we only spend 1/3 of our time on those professionally fulfilling activities, and 2/3 of the time is wasted on administrivia, like typing data in the electronic record, fighting over prior auths, chasing all over the hospital or the clinic looking for material or support. That's where a lot of the challenge comes from. And Penny, I think with the support for resilience in those activities, they are incredibly valuable. Most physicians and nurses become quickly cynical about them if that's the only thing that's offered.
Right.
Because the hidden message then becomes, the problem is that you're not able to cope. It's your fault. And here we're going to help you become more resilient, and not acknowledging that the problem is really the environment, the workplace. Once we get people on, if people understand, yes, we're working to help improve the workplace, then they're more likely to engage in those resilience support activities. But otherwise, that seemed like
of course, it's a both and tough it out.
But 10 years ago, that was the first go-to was, even doctors were saying, we're just going to help each other be more resilient. They really hadn't thought through it carefully enough. And now we're starting to see it differently, and that's a good thing.
There was like an overselling, really, of even this idea of resilience, which is a pretty misused and overused word. And I've been working with the clinical psychologists and physicians that I've been working with in developing the StressPal program. The deeper research over the last 20 years is around psychological flexibility, which is protective of resilience. This is around what is happening in the brain in the instant that we perceive that stressor or we experience that. What's that instant response? How do we adapt or learn from or not? And how do we ultimately recover from or not so effectively recover from it? And the exciting thing about some of these leading therapeutic methodology, and I'm talking here about mindfulness-based approach, acceptance and commitment therapy, interwoven and integrated with cognitive behavioral therapy, shows up in the research as very dynamic, efficient, and effective to learn and very durable over time in changing consciously, learning how that increase that capacity of our brain to change how we respond to stressors for our own protection, for us. So it's getting at these more, they're not newer from a standpoint of research, but they're newer from the standpoint of discussions around resilience, is around looking at what's happening in the brain and how can we change our capacity for our own benefit, cognitive, physical, behavioral benefit. And then as a group, when you start having a team-based approach like this, you start having teams with more of a shared language and understanding about the interface between those external stressors, their own patterned responses that may not be so helpful. And I completely hear you on this. Has to be a both and. You've got to be putting out the fire as well as helping yourself have the best PPE that you can have for your emotional well-being and your physical well-being.
That's true. Actually, human factors engineering studies have shown, and actually Dr. Michael Privatere, a psychiatrist from University of Rochester, has demonstrated that amygdala, as a result of all of the cognitive overload, the amygdala is actually increasing in size, increasing our reactivity to stress. And what you're talking about is helping reduce that reactivity, which is a key component for sure.
And learning to choose your response, catching it in the heat of the moment and catching that thought, that feeling, the heat of the moment, maybe that look you gave someone or that tone of voice, catching it. Is this helpful to me? It's that self-assessment. It's not only awareness, self-assessment, and then being willing to flexibly choose.
Absolutely. And we're putting so much burden again on the physicians and nurses to do that. The thing that's lacking the most these days is really the attention on practice redesign and leadership engagement and creating a culture that allows that. I don't know what all you know about what's happening with opportunities to reduce the administrative burden, things like IT with ambient technology and other things along those lines. That might be an interesting place to go with the discussion.
I'd like to say one thing first.
Yeah, go for it.
This borders on blaming the victim, because what we're asking people to do is have awareness of meaning and purpose, have awareness of choice and their emotions in the moment. When those sensors and those abilities get taken immediately offline when a person is overwhelmed and their energy accounts are in negative balance, they are incapable of doing the things you're talking about under the usual working conditions in a healthcare workplace, where by 10 o'clock in the morning, you're a half hour behind. I can just keep going, all the stuff that's going on, but let's just make sure we don't start blaming the victim for not being aware enough when they're overwhelmed and in survival mode, because it's triggered every day on the job.
Right.
We have to create an environment where those things are even possible.
And then if the administrative team decides to make rounds and come around and ask people how it's going, every clinician has the decision to make. Do I lie so I can try to at least stay just a half an hour behind and just tell them everything's okay? Or do I take this opportunity to tell them the truth? And that's going to get me 45 minutes more behind and I'll be over.
Rounding? That's something only guys like Paul Duchenne does. Because it's like, I know that my clients don't get rounded on. And because here's the trust level in most organizations. And I've sat in front of audiences and asked them to raise their hand. When was the last time your leader showed up when you weren't in trouble? They know automatically if the leader shows up unannounced, they're in trouble, because that's the only circumstance in which the leader would ever show up. The level of leadership in American medicine is atrocious. And the leadership habit that is completely missing is not rounding, Paul, shadowing. And I'm right when I say this. That's a vanishingly rare skill.
So rounding, we can consider being management by walking around. It's 20, 30 years ago. It was talked about as a great new concept in leadership and management in every industry. But you don't see what you really need to see. So it's really management by following around, which is shadowing, which is one of the things I instituted as CEO that was really life-changing. At first, when I took my CEO job, people want a doctor CEO to be practicing part-time to feel the pain of the rest of the physicians. And what I found was I wasn't able to practice frequently enough to really stay current, and I didn't want to become a bad clinician. So I stopped seeing patients, but I substituted shadowing. And in doing that, I got to see the pain of every specialty, not just the pain of a family doc working in urgent care, but to actually see it's different for a pulmonologist than for an orthopedist, than for a pediatrician, than for an ophthalmologist. But they all had specific things that were driving their pain. And then that enabled us to really start to focus more specifically on things and make a difference better.
So I'd like to get to the IT and AI in a bit, but would like to ask all of you, each approach, as we've seen from what you've said so far, both approach the topic with different lenses, different techniques. And I'd like to talk a little bit with a little specificity about what you do, what you recommend, and how you address burnout in practice. You can go first, Penny, if you'd like.
Sure. I know that Dyke and Paul will do an excellent job around the organizational and fixing processes, and those are very important contributors and drivers to burnout and what approaches there are. We focused in the piece of how can we develop tools that are effective, affordable, strictly grounded in the science around how people around this kind of work. We developed an all-in-one kind of program that has both accredited digital content that's self-directed, a very high production value, a lot of really fun to do, very engaging around essential resilient self-care and burnout prevention. And we coupled that with a burnout community, with a peer support community that's customized for and by the organization. So their own cohort, their own facilitators can come in. It's all anonymous, comes first name only, optional to participate, but it's a great place for organizations to make it their own and add their own wellness initiatives. And then we have a safety net resources on the prevention side and built-in metrics. We're just doing a project right now in a data and analytics with George Mason University and its partners around the country, American Essential Hospitals, a community of partners. Largely was nurses. I think about 60% nurses, another 15-20% of advanced practice providers was offered to workforce. We see in that some strong indicators of change around performance, communication, reduced burnout, and stress. So I'm sorry, we don't have our analytics yet on the PSS and the BRS, which are two validated assessments that are pre-post in our program. But we have done some analytics on some of the other areas. I'll just share a few with them. 97% of graduates of the program, since engaging in the program, I've learned strategies to function effectively in pressured interactions and situations. 94%, I'm better able to diffuse stress-triggered responses and communicate more effectively with others. And I'm going to share one more. 96% over the course of this training, I've made progress in my ability to flexibly conduct my life in ways that align with my personal values. These are all anonymous responses, and we're really delighted to see the kind of perception. There's pretext also, but that's which we're also analyzing, and I can't wait to publish this article and see what we find on looking at these both valid assessments. But these are the kinds of impact that we're seeing, and very high adoption.
I didn't disrupt your train of thought, but the we is StressPal, I believe. Is that correct?
It's George Mason University, its partnership organizations, healthcare organizations around the United States. And our program was the resilience training program that the HRSA grant funded for that project. So it's a bigger we, what I just described to you.
Everything I do is based upon our experience as a team of coaches. There's 6 of us that work together, all trained in my burnout prevention techniques, but all of us are physicians, ICF certified coaches. Last time I asked, between the 6 of us, we have 178 years of clinical practice experience. And what we do is ask our clients when they graduate from our coaching program, what are they actually doing differently than when they came in? And we have specific ways to measure their distress when they come in, practice satisfaction, and what I call the Venn of happiness, the overlap between your ideal practice and this practice. And so what we've developed is a whole set of tools that are split into 4 different groups. Number 1, a specific system to always be creating a more ideal practice, always be moving your current practice towards a more ideal state as you define it. It's got nothing to do with me. What's your ideal practice? Second one, get home sooner tools. And the digital scribes fit right into this. It's probably the biggest advance we've had in a long time in the most important stressor for doctors. Balance and boundaries tools and our single breath mindfulness technique to help people be the eye of the storm. Now, you can learn that in a coaching one-on-one way. You can learn it from trainings that I do. You can learn it from the book. You can learn it from our 86 video training library, Burnout Proof Online Workshop, which can be purchased individually or as a corporate subscription and branded to your institution. I was just in a talk with the folks at Sutter, and maybe they're going to put all 35,000 of their people on the system pretty soon, which would be very exciting. So digital, on demand, personal one-on-one coaching, but it's all based in reality. I don't slow down to do p-values, but it all works because it's not about me or what I teach. It's about what my clients are telling me is working for them in the real.
Well, that's great. That's great. And only slightly ironic because that you don't have a systemic, but of course, that's not what you do. Or
I do work with leadership teams who will allow us to come in and the second line of business that we do is our quadruple aim physician leadership retreat. I've trained over 300 wellness champions on 4 continents. And I actually am involved right now with Christus Healthcare doing a cohort of 20 of their folks that'll be wellness champions at each of their regional sites when they graduate. We're in a 1-year trail out every other week coaching support for that. So we do operate both at the individual and at the system level. But I'm not a guru ex-CEO like Paul is a total outlier, man. He is one of the good people of Lean and a great guy as a CEO with an impeccable track record. So listen to everything he says right now.
Okay. We're listening. Thanks, Dyke.
We've all built on each other. I remember it was 10 years ago, I first saw Dyke present about burnout at a group practice improvement network meeting. And really, I was at the point of transitioning into coaching and it really inspired me. So we've really supported each other over time. What I do now, primarily, really my big focus, and I have one partner in this, Bruce Cummings, who's a retired hospital CEO, not a clinician, but was in CEO roles in hospitals and health systems for 40 years, including working within small places in rural areas as well as within Yale, New Haven. We have a 5-step process that we use. It starts with education and really going and teaching medical staffs and leadership teams the realities of burnout, what drives it, and things that can be done to address it. Following that, if people are interested in engaging, we actually start to work on a treatment plan for the organizational dysfunction. So we start with a diagnostic, actually interviewing many key stakeholders in the company, as well as looking at all the performance metrics, because we want to do this work in a way that reduces burnout, improves performance, and actually increases performance on the dashboards that every health system has. When we then take that diagnostic information, and the third step is to present it in a facilitated meeting to the leadership of the organization with some key physician and non-physician leaders in the room. We're using that to help them design interventions that'll improve for them specifically. So we don't come in with a cookie cutter. These are exactly the things you need to do. We give them the information about what their challenges are, help them guide them towards decisions about what things they can implement, and walk out of that meeting with a specific implementation plan that includes who is going to do what by when and what they expect to see change in terms of improvement in metrics as well as processes. Then to actually implement that, we can support that with a number of on-site work there. And following up from that, just keep an eye. The fifth step is just help keep them in the system, introduce them to other like-minded organizations and keep the process going. We're actually scheduled to do that next week at a children's hospital in the Midwest. It will be there the full week, working with them through that process. And we found actually one of the big challenges these days is most health systems, everybody's stressed and strained for staffing and support to just get the work done. It's very hard to find a medical assistant. It's a little easier to find nurses, but to actually get enough people and have enough capacity to do improvement work has become a major challenge. We had one client where we wanted to do soup to nuts, a complete redesign of the workflow in their primary care offices. And they realized they did not have capacity for that. So instead, we went in and focused on a daily meeting that got their day started and also addressed issues around, really addressed all the 6 drivers of burnout in the process and improved metric performance. We had an initial pilot program that we agreed we'd have 3 months to launch it in 6 sites. It got so much traction that by the end of the 3 months, we were in 14 sites. A year later, we were in 100 sites. And they have seen a significant improvement in all of their performance metrics, not just burnout, but decreased turnover and quality, safety, access, you name it, performance improvement, continuing now for 3 years.
So have you published that, Paul?
We are not yet
Catalyst or something?
We're getting one more round of results. And then we have actually presented it at the American Conference on Physician Health, just under the catchy little title, Reducing Physician Burnout in 15 Minutes a Day. Yeah. It's basic. When you step back and look at it, it's basic stuff, but everybody's so busy, they don't even have time to do that. So
basic stuff delivered in an inviolable structure every single day. And let me just say too, I don't think that if this is going out as a general webinar to general practitioners, the regular doctors and nurses in the front lines, that we can wrap this up without talking about the collapse of the workforce of doctors and nurses that will happen between now and 2030. Because I have yet to talk to anybody who thinks that whatever we call this current, I'm going to use my quote fingers, system, can't last past 2030, simply for demographic reasons. The shortage of retiring doctors and nurses make it so that I think that the race to make a digital doctor, not just a digital scribe for a doctor appointment, but a digital doctor is on, because I think that's where a lot of the venture capital and angel investors are going, trying to make a digital doctor. What do you think, Paul? What do you think, Benny?
I think that it's interesting. I think it is a race, but I think the race is going to be slower than we thought. The latest studies coming out, as much as we are avid supporters of a digital scribe, ambient technology, about a third of doctors actually engage deeply in that when it's first offered to them. And then another third are gradually taking it on, and a third are really resisting. And so it shocks me. I think of all the things people complain about, that data entry is the main thing. And still it's hard to get people to do that. And it's just with that, let alone all the chart review and follow up and managing complex chronic disease. I think we will get there. 2030, I think, is hopeful. Maybe it's the same thing as hoping for joy, but the more we can all support it, the better.
And what I'll say is that I have predicted that what will happen is the productivity boost that you get from being able to use a digital scribe and be a power user of that technology will make that a requirement for a job in the future. And the doctors who resist and either half-heartedly adopt or refuse to adopt it will fall by the wayside. And many of them will age out because these are the older doctors who are resisting it. But I think at some point in the future, you're going to have to be facile with some form of digital note-taking to get a job going forward. It's not right now, but it will be.
Yep. Hey, we'll get you old dogs that have all learned how to be digital. If we were not digital natives, so I think you're right.
I remember loading Apple with floppy disks when I first started to use a computer. I learned to type when I was 40, for heaven's sakes.
Did you guys like to talk about the technology and AI and the scribe as well as the path that Dyke forecasts?
Yeah, I think the key, I really do think when we, that statistic, we spend a third of our time on valuable, professionally fulfilling work and 2/3 of our time on administrivia. I think we truly have the opportunity for the first time to flip that ratio. And when we do that, just it releases so much capacity for ourselves to have both work-life balance and focus when we're at work, and potentially, with caution, even increase productivity while we regain or develop further work-life balance. But it's going to take more than just the digital stuff being put on top of our current workflows. It really depends on redesigning the workflows to maximize the value of that. And that's where I don't see a lot of organizations making that effort yet. But if there's intentional redesign to incorporate the great value of those digital tools and the daily meetings in every location, because there's all these unanticipated consequences that come up that have to get adapted and dealt with. Putting those three things together, deep redesign, daily adjustment, and intense introduction of the digital, not just the ambient scribe, but all of the other support that comes with it, we do have that opportunity. And that's where I'm hopeful. And whether it's a fully digital doctor or doctors that are working at a much higher capacity, it's instead of thinking of it as artificial intelligence, it's really augmented intelligence, helping us to do that job far more effectively. Often talks about we never used the Krebs cycle, even though we studied so hard on it in medical school. Just trying to keep track of every new development in the practice of medicine is impossible. And that's where these tools can truly make a difference for us. Clinical decision support and things like that can be powerful.
My perspective around this is around the learning environments, and it is a way that is very important in terms of you're thinking of reputation, recruitment, retention, that opportunity to develop competency around areas that are important in your well-being and your functionality is critical in anything you do in that area. I know we gave tremendous attention to how can we make this absolutely seamless by introducing a program that a more inclusive peer support that can be rolled out and personalized to your organization. We wanted to make everything about the technology consistent with what real people, real healthcare workers and professionals are saying they need, and to make it seamless in operation so that and technology support, top-notch technology support. So you're not, from our perspective, you're not introducing or offering something that hasn't had the intensive look in the development stage by people who would be using it and by people who would be administering it. And you're not putting any more burdens around the technology side of it and customer service. So there's a whole lot of stuff around that I think has to come off administrators who, as Paul was saying earlier, are very high levels of stress now. That's not going to play out well in communications and relationships toward building trust if people are increasingly stressed by the technology and requirements of the technology. So as the developers of these programs, it's very important that you're super mindful to create not only no new burdens, you make their life easier. That's a clear and intentional focus. And even if it takes iteration and testing and rebuilding and reiteration, that's just what you need to do as a responsible producer of something that's going to be on the digital technology side.
I'd like to talk real quickly about 2 caution points about the use of digital scribes. And by the way, they're trained on the ChatGPT-like LLM, large language model AI software is trained on 1 million family practice notes. They shove it down the gullet of the program until it can make a note like a family doc. Even, oh, by the way, at the end of the visit, it can do it. And it's shockingly accurate if you trust it and then become a power user of it. The challenge is, and I've asked this to audiences of hundreds and hundreds of doctors, hey, if this can reduce 50% of the time you spend in the chart, how long do you think it'll take for your boss to ask you to see more patients in a workday? You know what the average answer is? About 10 minutes. Now, the question is, this will be used to drive patient volume. And I have 2 concerns about that. Number one, it's going to increase burn. And I say that because right now, we may not realize it, but documentation burden may actually be a good thing because it slows you down to just 20 or 30 patients a day. And you can cognitively handle the decision-making of that amount of interactions. But if I jack a primary care doctor up to 40 patients a day because he's spending 50% less time in the chart, we may run into cognitive barriers. We already know about decision fatigue. We already know about compassion fatigue. Maybe there's some other deeper thing than burnout that happens when you remove the friction of documentation and just jam the high risk, high emotion encounters that we put in our work days. How deeply will we injure people if we take the governor off of the number of patients that they see in the day and make it a requirement of their continued functioning in that job? Or I'll just put a digital doctor in your place. Now that's a bit dystopian, but nobody's doubting that it could happen, okay? What do you think about that? I'm concerned for the deeper things that can happen in the brain.
Boy, I don't think we have time to get into this. There's so much to talk about there. There's no question cognitive overload is an issue, but so much cognitive overload comes from the way we're doing things currently. I don't foresee, back in the old days when we all wrote a brief illegible note on paper, primary care docs with very simple problems that they were dealing with could see 40 patients in a day. Most docs I talk to now are seeing 15 to 18 patients a day. I don't know that anybody's ever going to get up to 40, but even a minimal marginal increase can cover a lot. And I'm not out here advocating that every doctor has to see more patients. I think we just have to find the right balance that maintains financial stability. How do we keep these systems that are on the teetering on the edge of financial collapse? How do we keep them going at the same time we make it a livable working environment? So there's a lot to do with that. I think in order to deal with that technology challenge, which is real, the deeper problem still remains in the C-suite. One of the things I haven't brought forward as much, but we certainly see, is that there is deep distrust and disrespect between the people in the C-suite and the frontline clinicians. And if that is probably the deepest root cause problem that if we could resolve would help make all of the rest of this so much easier. And techniques to do that. The key is making the case well enough to the C-suite where they're going to make the investment so that we can then go forward with those techniques that then can help all the rest of the great things we've talked about really get put into place.
Right on it. 53 minutes past the hour, we finally get to the heart.
So would you all do a summation so we can last parting thoughts? And all that was very powerful, Paul and Dyke, about the fact that basically you can't just drop a piece of technology into a system that is essentially broken. We really need to figure out.
I wish that was true, but it's going to happen everywhere.
Okay. I'll leave the forum open to all of you.
I've got a jet. Can I go first?
Go for it.
People become pessimistic when we always talk about system level change. Never underestimate the amount of change that you can create for yourself, your work team, your family, your patients in the day? Like, do you have the ability to throw up a portable magic bubble that you carry with you through your workday that can give you some joy, if that's what you're looking for? How about fulfillment, meaning, purpose, sense of satisfaction? Never underestimate what you can do in close proximity to you and make the differences you can make in your workday. Say thank you, ask questions, acknowledge your people, and take a big breath when you put your hand on the doorknob. Let go of anything that doesn't need to be there, and just open the doorway to a focused patient encounter and enjoy your folks, enjoy your people, enjoy your teams, enjoy your family, and then get out of work. Go weed the garden, have a good time in between. That's it for me. I'm out.
Thanks.
I'll then jump in. It's been a wonderful conversation, and thank you both for all these perceptive thoughts. And there's the part of me that is the advocate. That how can we find ourselves in a better place to be advocates for ourselves, for our teammates, for our organization? How can we become better collaborators and really creative problem solving for this enormous and immensely complex challenge that faces healthcare organizations at the system level and the people that are working at this such essential work that every one of us will need ourselves in our life and will hope to have the best care that we can have. And I think I want to close by saying that I feel the importance of this, the leadership piece, and the importance of supporting concurrently. Now, how can you change? How can you lead better? And how can you right now arm your folks with learning environments where they can become competent in leading best practices, interventions that have immediate application for them right now? I think both are a very winning economic opportunity for organizations. I would hate to see them miss it because we can start bridging fields of learning here to advance the top down and the across and up approach to solving these enormous challenges, which I feel will come. I feel hopeful.
Thank you, Penny. And Paul, can you take us out, as it were?
Sure. As we've talked about, the system is on the verge of collapse. Individual health systems that want to succeed have to recognize that we have to fix the workplace. And to fix that workplace, it's going to take leadership engaging in a completely different way than they have. Those leaders who engage in that different way, that really engage with their clinicians, are the ones that are going to win. Because as they engage, they'll make the changes that make the difference, where physicians feel respected, where they're able to practice their craft, and where they'll support the system because the system's supporting them. So it comes down to leaders that decide that they want to win. And it may actually come down to boards of directors that are willing to actually hold their CEOs accountable to recognizing this and actively engaging in these kind of changes.
Thank you, Paul. Thank you, Penny. And thank you, Dyke. This has been a very informative hour, and I hope that we're on the first steps to significant change for physicians, nurses, clinicians, and our patients. Thank you.
Thank you.